Hi everyone, it's Heather, and since I am now in my final semester of respiratory school and I will be graduating and passing, I intend to pass the first time my boards in less than 3 months, I thought I would do a little bit of a look back and tell you about 6 things that have surprised me since I started respiratory school. These are in no particular order, but the first thing is the difficulty I have had retaining certain information. I tend to memorize things easily. Most of the normal values I've been able to stick in my head really, really easily, but there have been a couple of things that I've really had trouble wrapping my mind around, not understanding them, but just retaining the information. There's an awful lot to remember when going into respiratory school. You're given a whole lot of information, a whole lot of normal values, and general things that you just simply have to memorize. There's not really a trick to memorizing most of these things. It's just flat out repeating it, repeating it, repeating it until you've got it stuck in your mind. And for some reason, there are a couple of things that I just have really, really struggled with. If you've watched some of my other videos, you'll know that already that hemodynamics is one of them. I'm still struggling with that. I'm still really, really having a hard time remembering a lot of those normal values. And for some of them, what it means when certain values are increased or decreased. So that's a big one. PFTs are another one. I've given up a little bit on trying to really, really remember everything I need to know about PFTs, and I've just kind of generally told myself, as long as they hit 80% of the expected, then we're good. So sometimes there's tricks like that. You still have to understand to a certain extent what the different PFTs mean. So if you are just starting out and you don't know, PFT is pulmonary function test, and that is part of respiratory school. That is some of the stuff you have to learn, and it's one of the specialties that you can learn to do after you finish your basic respiratory school and you have your credential. It's something that I am not super interested in, but it is still something that you sometimes do bedside spirometry and you still need to know how to do some of these things. Super, super important to just constantly review as you're going through school. Don't ever think, okay, I've learned that, I can move on. No, just continue to review throughout your entire time in respiratory school, because that's really going to help you when you get to board exams and need to know all of these normal values and everything for board exams. Number 2, so that was number 1, was difficulty retaining information. Number 2 is school versus real world. So there are certain things that we have been taught in school that I have so far never seen out in the hospitals, and it's doubtful that I ever will. Now, some of this is going to be dependent on your hospital and your area. But like, for example, we spent, I think, 2 weeks going over IPPB, which is intermittent positive pressure breathing. It's a machine that is kind of almost like a precursor to ventilators that we use now. But some places apparently still use them. Some places might use them on an emergency basis. I have seen exactly one of them in a storage unit, a storage room in one hospital that I've been to. And other than that, I have never seen one, and I have definitely never seen one actually used in any of the hospitals I've been to. But I hear that in some places they do still regularly use them. So I guess that's just area dependent. But that's certainly something that we spent a fair amount of time going over in school that I don't expect to ever actually see. And then on the flip side, there's some things that I've seen in the clinical setting that we didn't really go over in school, or if we did, it was very, very briefly. So APRV, which is a mode that can be used on a ventilator, and AVAPS, which is a mode that's used on like one of the BiPAP machines we have at some of the hospitals I go to. And those are things that we just kind of touched on very, very briefly in school, but I have seen a fair amount of use of both APRV and AVAPS in the hospital setting. So that's something I've struggled with a little bit, having not had a whole lot of background in it at school, is getting into a clinical situation where they're like, oh, well, we're going to put this patient in APRV, or, put that BiPAP in, put it on AVAPs, and going, oh, what does that do again? So some things you're just going to have to learn once you get into the clinical setting. So that's been interesting because, there are certain things that are on the board exam that maybe don't really correlate to real world. So if you're on any Facebook groups or anything, you might see people talk about the NRBC, NBRC hospital or real world hospital, because those can be two different things as far as what decisions you make and when you make those decisions. There are certain things you're going to say, this is what I do for my board exams, but that might not correlate to what people actually do in the hospital in the clinical setting. So number 2 was school versus real world. Number 3 is how much the daily workload in the hospital changes, meaning you could be super, super busy one day, go, go, go from start to finish of your day. And then the next day you're sitting on your butt in the respiratory department, just kind of not having a whole lot to do between your rounds that you do at any given hour. Some of that's going to depend on what area of the hospital you're in, if you're in ICU or if you're in NICU, PICU, if you're on floors. And some of it just depends on, how many Q4 treatments you have versus how many twice a day treatments versus, all these factors come into play. Weekends versus weekdays. Weekends tend to be slower as far as you are generally not transporting patients to procedures like CT and things like that. You are not as frequently getting patients admitted or discharged. So weekends are often slower, but that doesn't mean you aren't still going to get some workload. Some weekends I've had have been much busier than weekdays. So it's really difficult to kind of gauge how your day is going to go. And it might be you have a really, really slow morning and then you are go, go, go all afternoon because maybe there's a rapid and then a code and another rapid, or, PRN treatments that all of a sudden you weren't expecting to do PRN treatments for this patient or that patient. And so it's interesting to see how the workflow changes from day to day as well as from hour to hour. And that's something I guess, expected it to be a little more steady across the board, and it definitely has not been. It's been much more changeable than I expected. So that was number 3, daily workload changes. Number 4 would be how things are done at different hospitals. So some people live in areas where, maybe there's only one hospital to work at. The area where I live in, there are lots of different hospitals and several that I haven't been to. I can think of 1, 2, 3, 4, 5, 6 off the top of my head, and 1, 2, 3, 4, and there's at least 4 others that didn't even come to mind with those first 6. So there's probably a good dozen hospitals within easy driving distance of me, where they have RTs working, and that doesn't even count long-term facilities and other places where RTs might be working. And all of those hospitals do things slightly differently. I happen to be in a fairly conservative area of the United States where a lot of the hospitals do not have RTs doing intubations. Some don't do arterial punctures or A-line draws. Nursing does all of that. It's interesting to see what the general scope of practice and what the protocols are at the different hospitals. So if you are in an area where there's a bunch of different hospitals and you don't know which one to work at, you don't know which you like, I highly suggest really, really trying to go to several different ones to do your clinical rotations, because some people are going to find they really like, hospital A, where there's a lot of ICU beds, where they do a lot of work with vents and they don't do a lot of floor work. There's a hospital here where RTs pretty much never do breathing treatments. They're not on the floors doing that sort of stuff. They are really focused more on the critical care side of things. And so when you go in for your shift, you are assigned maybe to this one ICU, and that's where you stay. Your whole shift is just in this one ICU, seeing this certain set of beds. Whereas another hospital you go to, you might have, this floor and this ICU, or maybe you only have one ICU, or maybe you only have ER, but you also have, there's a whole different slew of things that you might get assigned to in these other hospitals. And so it's a good idea to try and do your clinicals at a lot of different places to see what you like best, because that's going to be different for everyone. Some people really don't want to do floor care. Some people really don't want to do as much ICU care, or maybe they want to be around the whole hospital more than just in one ICU. So that's something that's going to change from hospital to hospital. Your protocols are going to be different as far as, in this hospital, it might be protocol for RTs to be more independent in making vent changes and then informing the doctors, these are the changes I've made. And in another hospital, it might be more centered on, saying to the doctor, okay, these are the changes I think need to be made. What do you think? And seeing what the doctor wants changed. And again, how you prefer to work is going to vary from person to person. Charting systems are very different from all the hospitals I've been to. I think I've been to 3 different hospital systems, and so that's 3 different charting systems, and all extremely different. And so again, that's something, it's a good idea to get exposure to all those different things. So as much as you can, go to different hospitals and see what they're like. So that was number 4, the different hospitals and the different way that they run. Number 5, I think, would be, I've been a little bit surprised at my personal emotional reaction to various patients, to various situations. So I've done several terminal extubations. If you don't know what that means, that's when someone is on a ventilator and the choice has been made by family and doctors and a combination thereof to go ahead and extubate this patient and only do kind of comfort care measures and allow that patient to pass away, not on the ventilator, and not trying any other life-saving measures at that point. So I've done several terminal extubations, and varying degrees of emotion on my part, as far as, is this a very young person whose family is really upset and grieving? And obviously everyone's upset, but sometimes it's a terminal extubation of someone who's been very, very sick for a very long time, and the family knows that, this is the time for that person to go. And if it's not a trauma, if it's just the end of someone's very long life, there's so many different situations, and I've found that sometimes it's surprised me how emotional I've gotten, and sometimes, it's just kind of a, even sometimes with traumas, it's a, oh gosh, that stinks, let's go on to the next one, and I don't always know how I'm going to feel from one patient to the next. And then 2, it's been interesting, patients that you kind of get attached to, maybe long-term patients, or patients that come into the hospital frequently that you see on a more regular basis, and you kind of get to know them a little bit, and some of them you like and some of them you don't really like so much, and the different reasons why. And again, that's going to be different for different people. There are patients that other people maybe don't like working with as much, that they find kind of a pain to work with, that I prefer, and vice versa. So that's kind of an interesting dynamic sometimes, and something I've been a little bit surprised about. And I guess the last one, number 6, would be how quickly we did hands-on things in the hospital. I think I was expecting to do more observation and just kind of watch from the sidelines at first and then get hands on and do things. And that's not really how it worked. It was really kind of a, okay, you did it in lab, now do it here, on a real human being. So, like, for example, my very, very first shift at clinicals ever, we went to a procedure where, and this was in a operating theater situation where they were doing a thoracentesis. So this is not a completely sterile procedure as far as not everyone in the room is in sterile gowns and all of that. But obviously the doctor and the area that the thoracentesis is being done on is all sterile. But and I really was there just to observe. But this particular patient had some respiratory depression because of the sedating drugs that they were given. They weren't all the way out or anything like that. It's more of a local anesthetic procedure. Sometimes people are sitting up while they do this. This particular patient, this was more of an emergent sort of thing, and they were laying down, but they had a stronger reaction to the sedatives that they were given, and it caused them to stop breathing enough. And so then we had to bag the patient. So that I'm there during this thoracentesis on my very first day, bagging this patient. And to me, it seemed like a much more heightened situation than it did to everyone else, because this was something that they were just kind of used to. So that was interesting for that to be like my first day having to bag a patient in an OR for this procedure. And let's see. Oh, and then also with the hands-on stuff, certain things that I expected to be doing more often than I do. So, for example, we learned how to do trach care. So we do trach care frequently. We also learned how to do trach changes. I have yet, so I've been in clinicals now for like a year and I don't know what. And I have yet to see a trach change done. I certainly have not done a trach change myself. And it's something that I've been trained to do in lab, but still have never done. Another thing is nasotracheal suctioning. So putting a suction catheter down someone's nose into the back of their throat to suction out any gunk that they have. That was something I just did for the first time myself yesterday, so I learned how to do it in lab, and then just it never happened to come up when I was at clinical. So it's been interesting, the things that we did immediately and certain things that just haven't happened to come up yet. Another immediate thing that we did was the week that we got checked off on doing intubations, I found myself assisting during an intubation like 2 days after checkoff in the hospital. And so that was a little bit nerve-wracking, and I was a little anxious about it, but it was still really cool. But it was another one of those I kind of expected to observe more before actually being part of the procedure. So that's been interesting, just the things that you kind of get thrown into. And I don't know if everyone else expected to have more observation time, but there's that saying of see one, do one, teach one. And that really kind of is how it's been with some of the stuff is, you know, you see it done in lab, and then you're doing it in the hospital after you're checked off. And, that's just how it is. You have to be able to go, okay, I'm going to get in there and do this, because that seems to be often what is expected. If you've been taught how to do it, if you've done a checkoff on it, you are going to do it in the hospital. So that was surprising to me. So I would love to hear if there have been any things for you, if you're in RT school now, or if you're going to be starting this fall, if there are certain expectations that you have. I would love to hear about them. So drop them in the comments.